So next speaker we have Dr. ANAHITA Kate. She'll be speaking on HSV necrotizing keratitis. Now this entity is something which is very, very difficult to diagnose as well as treat. Dr. ANAHITA is faculty at LV Prasad Eye Institute, Vijayawada Center, and she did her fellowship from LV Prasad Eye Institute, Hyderabad, and previously she did her post-graduation from JIPMER, Pondicherry. Over to you, ANAHITA.
Thank you, Vikas. So, good morning, everyone. Today I will be discussing HSV necrotizing keratitis. When do we suspect this entity? How do we establish the diagnosis? And what are the principles of its management? So, this is perhaps the one entity in HSV keratitis which very closely mimics routine microbial keratitis. So, unless we have the clinical suspicion that this patient might have an underlying HSV infection, and because HSV diagnostics is not a part of our routine microbiological workup, we will miss out on these cases because routinely we do not ask for HSV diagnostic tests. So, how do we suspect that this patient may have an HSV infection? The first is if the patient presents with a chronic history of recurrent episodes, that they've had on and off episodes of redness, pain, and watering in their eye. The other is the presence of footprint scars, vascularization, and here specifically the presence of deep vascularization and atrophic iris patches, as can be seen in this picture here. So it is important to understand in isolation, none of these signs are specific for HSV, but when all of them are present together, this constellation suggests that the patient may have an underlying HSV infection. Another point that can indicate that this patient has an HSV infection is the color of the infiltrate. It tends to be more on the white side of the spectrum, grayish white in color, when compared to other bacterial or fungal keratitis. Now, both the images are taken from the same patient. The one on the left, the patient has an isolated HSV infection, whereas the one on the right, the patient has an HSV infection with a superadded bacterial infection. So we can see the difference in the color of the infiltrate. Again, this is not a diagnostic feature, it just suggests the presence of an HSV infection. So, how do we diagnose? Now, when it comes to diagnostic tests, there are some limitations that it is very important for us to understand. The first and the most important thing is these tests are not routinely available everywhere. The second one is that it takes time for the test results to come back, and we cannot wait for these results to come to start or initiate the treatment for these cases. And the third and the most important thing is that it does not detract from the diagnosis. So if the test comes positive, it does not mean that we need to stop our antivirals, especially if the patient is responding to it. So in the context of these facts, these are the tests that are available. And within these tests, the combination of PCR and IFA has the highest sensitivity and specificity for the diagnosis of HSV. IFA indicates the presence of the antigen and therefore it is diagnostic for an HSV infection, but this is not true for PCR. So even if you have an isolated PCR positivity, it does not indicate that the patient has an active infection, and this is because the HSV virus can be present in the tears of normal individuals. It can also be present in the corneal epithelial cells in around 15% of the population. And so to circumvent these limitations, we have tests such as RT-PCR, which quantifies how much viral load is there in the sample that we have taken, and therefore we can differentiate from a carrier status and an active infection. Now, let us look at how do we treat these cases. So we start with a therapeutic dose of oral acyclovir, which is 400 milligrams 5 times per day, and here we are talking about the oral form of acyclovir. Additionally, we start these patients on antibiotics because, like I said, we may not be entirely sure that the patient is in fact a case of HSV keratitis, necrotizing keratitis, because in these patients they will have an epithelial defect and infiltrate very similar to that of a routine microbial keratitis. Subsequently, we monitor the healing of the epithelial defect, the healing of the infiltrate, and when the culture comes back negative, and in the combination of these two factors, it is only then that we start the patients on topical steroids. Now here, the starting of the topical steroids is different from that of immune stromal keratitis, because in immune stromal keratitis, we start them at a higher dose, But here we start them at a low dose, 4 or 5 times per day. Again, slowly assess the response to therapy and then subsequently increase the dose. Once the dose has been increased, the tapering is very similar to that of immune stromal keratitis. So let us see these principles in the context of some cases. So this was a 53-year-old female who presented with this inferior paracentral infiltrate. You can see the color of the infiltrate is grayish white. There is a front of vascularization inferiorly, and there's an overlying epithelial defect. So the patient was subjected to a scraping, which was negative. And so the patient was started, because the clinical picture was suggestive of HSV necrotizing keratitis, the patient was directly started on oral acyclovir along with prophylactic antibiotics and cycloplegics. Subsequently, this was the response to therapy on oral acyclovir. We can see there is a decrease in the infiltrate. There's also near resolution of the epithelial defect. Subsequently, the cultures were negative. The IFA PCR was also negative, and so the patient was started on topical corticosteroids 4 times a day. And this was the response to the topical corticosteroids. Slowly, the dose was hiked up and then tapered. There was complete resolution with scar formation. This is another patient who had a long standing history, and this is what a chronic case of HSV keratitis often looks like. The patient will have footprint scars, significant vascularization. The surface may be unhealthy because of associated neurotrophic keratopathy. Here, there is an epithelial defect with significant infiltration and hypopion. There was thinning, so the patient underwent a TABCL and was started on prophylactic antibiotics and oral acyclovir, the therapeutic dose. And with this itself, there was a significant response. And again, the culture was negative, and so the patient was started on topical corticosteroids, and the patient had a very good response with the same. Now, this case I wanted to show because there can be this type of a picture, and it really helps us identify that this patient has an HSV infiltrate. So here, if we see, there is an inferior infiltrate, and on staining, the margins of the infiltrate have the typical scalloped appearance of a geographic ulcer. So this is also an indicator that the patient has an HSV infection. And if we go back to the first picture, we can see here the lesion that is extending from it also has a dendritic pattern of infiltration. So a very careful clinical examination can help us differentiate the microbial keratitis patients from the HSV keratitis patients. So this patient also again responded very well to oral acyclovir, and then subsequently we started on topical steroids, and there was a good response. This is another case where we can see that the epithelial defect has a very classical picture. The margins are tapered and there's a dendritic pattern over here. So staining, and here we can see also the margins are taking, there is a little bit of rose Bengal staining. So staining in a patient with necrotizing keratitis can give important clues as to what the underlying diagnosis is. Again, this patient had a good response, was started on topical steroids and had complete resolution. This is the last case. When you cursorily see this patient, you may again treat it in the line of bacterial or fungal keratitis. This patient has predominantly a posterior stromal and an endothelial involvement with a large overlying defect. So this patient was not very compliant to therapy and came with this kind of picture. Here, this looks has a more classical appearance of HSV because of the vascularization. And this patient on investigations was positive for both IFA and PCR. The patient, because of the thinning, underwent a TABCL and again responded very well with scarring to oral acyclovir and steroids. So to conclude, a high degree of clinical suspicion is very important to identify if the patient has an NSK infection. For this, careful clinical examination looking for the presence of vascularization, footprint scars will tell you that the patient probably has an underlying infection. Although diagnosis supplements in NSK, it is not necessary for it to be positive to start the patient on antivirals or even to continue the patient on antivirals. And for the management, oral acyclovir is what we give initially. Only after you see a response, you must start the patient on topical steroids. Thank you.